Back, and I think this will be an enlightening panel discussion. I have the privilege of asking really difficult questions that I don't have to answer myself, which is great. But I would want to start with introducing our panelists. On my far left is Annie McKay. She's president and CEO of Kansas Action for Children. In 2013, she became the founding director of the Kansas Center for Economic Growth, and during the past 3 years, transformed the organization into a respected and reliable statewide resource on Kansas budget and tax policy. Now, as she assumes the position at KAC, McKay will lead an advocacy organization that has spent nearly 4 decades as a voice for Kansas children and families. Next to her is Melody McCray-Miller, one of my former bosses. I hope she has good things to say about my performance in that old job. Please don't talk about that while you're on the panel. But through a career spent as a business owner, community leader, and state legislator, McCray-Miller has been a constant and consistent advocate for disenfranchised populations. Now, as a leader in local efforts to reduce rates of infant mortality, she continues to provide a voice for those so often unable to speak up for themselves. Next to her is Teresa Lovelady. She is president and CEO of HealthCore Clinic, Inc., formerly known as the Center for Health and Wellness. I was there at that groundbreaking. It was a marvelous place. She is a Sunflower Foundation Advocacy Fellow, an alumni of the Kansas Leadership Center, yay. She also participates on several community initiatives that work to impact infant mortality rates in the Wichita community, including the Community Action Team that raises awareness of infant mortality through collaborative action, Sedgwick County's Healthy Babies, Healthy Steps program, and as a past presenter for the annual Heartbreak and Hope Conference sponsored by Wesley Medical Center. And last but not least, Dr. Josh Umber, a family physician. And even before finishing his medical degree from the University of Kansas School of Medicine, Umber dreamed of founding a medical practice focused primarily on the patients rather than dealing with the traditional restrictions of government and insurance regulation. We should say that again. This dream became a reality in 2010 with the opening of Atlas MD, a Wichita-based direct pay medical practice. My name is Mark McCormick. I am the executive director of the Kansas African American Museum, which is the headquarters of a international study of medicine. No, it's not. It's just. But as I had mentioned in one of the earlier sessions, I was a career journalist and I've moved into other work. But the work of my museum continues to be about trying to get people to engage. And I believe that's why I was asked to be a moderator here today. I have a brief statement about why this issue affects me so personally. I'm going to ask each of the panelists to address that same question. I'll have a follow-up question that I would like for each of them to address. And at that point, if you have questions in the audience, feel free to raise your hand and I'll start calling on you then, although I'll have plenty of questions if you don't. But I wanted to begin with a quotation from Martin Luther King, who said in March of 1966, just a little short of 2 years before he was killed, that of all the forms of inequality, injustice in healthcare is the most shocking and the most inhumane. And I can remember growing up in a household and talking to extended family members about how they had siblings die at home because African Americans weren't always allowed in the hospital. And when I grew up and was in college and I'd done about 5 internships to prepare myself for my journalism career, my last internship, I was in this kind of no man's land. If you're an intern, you're not a full-time employee. You're a full-time temporary employee. So they decided that they wanted to hire me, but it would take about a year, so I just had to linger on the staff until I could be hired and have benefits. And in the interim, I developed some pretty serious problems with ulcers, and ulcers that bled. And while this was happening, the pain was unimaginable. I went to newsroom management and I said, well, I really do need help. I don't have insurance. Is there anything that you can do? And they offered me Pepto-Bismol. How's that, Doc? Did I do the trick? But I'm sharing that because things got worse and worse. I ended up being hospitalized for more than 30 days. I had 2 serious surgeries. I had my entire colon removed. I threw 2 DVTs, 2 serious blood clots. And all of this, I think, was preventable had I simply had coverage. And I'm sharing that because, you know, we talk in media about being objective, and I think that's a myth. What we have to be is fair. And I'm trying to be transparent about coming to this issue from a point of view. And I'm trying to be fair about it, and you need to know that about me. But I'd be curious to know from each of you, and I'll start with you, Annie. Why is this issue so important to you?
Yeah, I mean, I think, so as a native Kansan, I'm certainly interested in everybody attaining the highest level of health. And as I think about it from the perspective of Kansas Action for Children, I mean, this means full and equal access to opportunities for all Kansas kids. Thinking a little bit earlier about what Dr. Carmona said about your zip code shouldn't matter as it relates to your health outcomes. And then philosophically, Tanya Lewis-Lee said that we have to care about those people, right? And those people is a whole host of communities across the state, because eventually it's going to come around back to us. And so I think that those things kind of shape why it matters to me.
Ellie?
Health equity, health disparities matters to me, and I'm going to probably read most of this because I want to make sure that I don't miss it. I think that this issue is indeed that important. We have health disparities that persist across populations when considering race, wealth, geography, including rural versus urban, and education, and it goes on and on. However, the preponderance of these disparities are reflected in and impact disproportionate numbers of African Americans and Latinos. And there are so many challenges that go hand in glove with it. So the challenges persist. Lack of access to health care, which we just heard from Mark McCormick, compounded by the refusal of our state at the state level to expand Medicaid. Discriminate behaviors, we heard that from Dr. Carmona this morning, exhibited by healthcare personnel, causing barriers to timely and adequate care. Social determinants, all can make good health and wellness difficult, if not impossible, to achieve. That's why health disparities and working on health equity is so very important to me.
Well, health disparities matters to me because I care, first and foremost. And why do I care? Because I was that uninsured child growing up, and I was that uninsured parent at one time, and I lived it, I walked it. As a former patient at the Center for Health and Wellness, and I found the Center for Health and Wellness because I had a 2-year-old that was uninsured and needed immunization, and trying to figure out how I was going to make that happen. Being uninsured myself and knowing that I needed to get access to health care, places like the Center for Health and Wellness and other safety net clinics open their doors up, and they help and assist people who come from those walks of life. And as I work my way up through college and through life, and to end up now as the CEO of Health Court Clinic, I care. I care because I know what it feels like to present somewhere and not have what you need to get the care that you need, and not feel like you can be an advocate for your own care. I know what it feels like to show up somewhere and people look at you like you're dirty or you got something on you, and the only thing you need is help, and hope, and courage, and support. I care about health disparities because without us all looking at it in a way where it could be you, it could be your child, it's probably your neighbor, it's somebody you know, we're all one step away from a health disparity ourselves and then get diagnosed with something chronic. watch your finances go away if you have finances, or get diagnosed with something if you're poor, and watch what happens to you and your family. So we have to care.
Nothing puts that in perspective more than having a child that you can't insure. Doctor.
Well, I don't think there's a better answer than because I care. As a physician, I think we struggle as a society to fix the issue because physicians have struggled to lead on the issue because we haven't figured out the healthcare system yet ourselves. And I think often because we keep moving forward in the wrong direction. We keep looking at how do we do more of the same rather than how do we innovate to get a better end product, a better solution. I care about my patients, and we wanted to innovate a better solution for them and for us, because even though it's not great for patients, it's equally bad for doctors' health. We lose a physician a day to suicide. 60% of family physicians will say they're burnt out. How are we supposed to help our patients get better if we don't know how to get better ourselves? And I think a lot of things come down to a system thing. Good people practicing bad medicine or politics because of a broken system. And so if we can fix that piece of it, I think there are amazing opportunities on yet to be realized on how we can improve outcomes, affordability, access, convenience, etc., in a way that gives us a 10x growth in quality and improvement. And that's what we've done with our mission and our approach.
You know, I did a little reporting on you before you got onto the panel, and I think you figured something important out, and I hope you get to that. I want to give you some time to talk about that in a little bit, but I have a question for the entire panel first. Do all people deserve to be insured? In other words, is this a right that we want extended to all citizens at public cost? I'll start with you, Doctor.
I'll probably take an unpopular opinion here and explain myself in the brief time we have. No, healthcare is not a right because we have to define what rights are. And with the understanding of what negative and positive rights are, is healthcare for all a valid goal? Absolutely. Should we all have clean energy, clean water, clean food, homes? Yes. Someone has to pay for that. And as long as you have to pay for it, it cannot be a right. And that can roll into a deeper philosophical argument about what is and what is not rights. But you cannot have a right that negates me to involuntary servitude. Someone has to be the nurse, to be the surgeon, to be the pharmacist. Someone has to provide the care and create the bandages and ship the bandages and make the bandages and run the clinic and clean the floors and keep the lights on. I'm chairman of a wonderful non-for-profit here in town, Rainbows United, who was doing amazing work for years, but not being run like a business. And as such, they almost collapsed and had to go through bankruptcy because they weren't managing their resources in an effective way. If they closed, hundreds of and thousands of kids would not be getting the quality care that they're getting now. Even though the goal is laudable of getting wonderful, affordable care to everyone, the end doesn't justify the means justifies the end. And now that they are run like an effective business, they can recruit, retain resources, and do more good for more people, actually at a less of a cost per individual.
So it's kind of like what Dr. Carmona was saying earlier, that my right to smoke is going to encroach on your right to have to pay all of my bills once I get sick.
So, laudable goal, but not technically a right.
Who wants to tackle that next?
I can debate myself.
I'll
I've done that
tackle
before.
it. I'll tackle it. When you look at health disparities, actually, I think that it is rooted in the very fact that it should be a right. And the reason why is because actually health disparities are preventable. They are preventable differences in the burden of disease, which sometimes I pronounce as dis-ease, but disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. If we as a nation believe, and certainly as a state, believe that every person has the right to live a good life, then it just makes sense to move away from what I would call a sick care model. That is, wait for somebody to get sick and then you treat them. And in fact, you're going to treat them in death or to death. What we should be doing is looking at it from a front end and front loaded perspective, where we share our resources, target our resources, such that we put those dollars at the front end, or prevention, and spread it across everyone, not choosing and picking who it is that we're going to leave to the last, that is that sick care model, and then say that we have to take care of them. And we end up spreading all of those dollars across the population. I'm just going to give an example, would be an emergency room. So if you're going to take that perspective, then those individuals are going to end up in your and our emergency rooms. And when we need care, we're going to pay for that. We're going to pay for the persons that did not receive the preventative care that could have been so less costly than paying for it at the back end. Health disparities also cost our nation. I think there was a reference made to that by Dr. Carmona. Health disparities cost the United States approximately $82 billion. $82 billion in higher health care spending and loss of productivity. Can't we agree that good health is associated with positive social, political, economical, educational outcomes? If we agree to that, then we should be able to agree to collectively target our local and state resources towards eliminating these preventable health disparities.
We got 1 for, 1 against. You kind of used Dr. Josh's same logic, but kind of in a different way.
And I twisted.
Annie or Lisa, do you want to wade in?
I'm just gonna sort of build off of what Melody was saying, and I think it's about investing in the front end. And if I look at this as it relates to Kansas kids, there's no reason why we should be facing some of the disparities we are. We have resources in the state. Earlier, we were talking about infant mortality, and just at the end of May, the program that addresses infant mortality in Kansas was cut, as were other early childhood programs. We have a designated, devoted stream of money in the state of Kansas to support early education, to build on that front end and prevent those costs in the future. And we're sweeping that and not investing for a variety of reasons. So I would say that there's no reason why we shouldn't be eliminating barriers and access to healthcare services and other preventive services and programs to make sure that all Kansas kids have an equal shot at a healthy childhood.
Really, beyond kids. I mean,
Kansas Action for Children, ma'am.
I got you. But it's to clarify, you agree that this is a right that we ought to be providing to citizens at public cost.
Yes.
That's 2 to 1. Hold on, we got 1 more to wade in.
Well, it's interesting because I'm going to look at it from a patient's perspective. I mean, ask a parent or grandparent in the emergency room with their newborn baby that's not thriving, and ask them if that child, that uninsured baby, should have a right to health care. And ask that doctor or that ER person that's going to register, ask them if that person should have a right to health care. Because we could talk about the dollars, and healthcare funding is so siloed. I mean, you go to this place for this, you go to this place for that, and each one has their own reimbursement mechanisms, and not just medical. When we talk about mental health, we talk about substance abuse, we talk about going to the cardiologist or the podiatrist. I mean, you got to get a referral. You got all these other hidden costs that are built in our system that's making the cost of healthcare just out of reach for, again, that mom who shows up at the emergency room with an uninsured child that says, my child's not thriving, do do I have the right to health care? But I think we as leaders in kind of the healthcare field and industry, if you're in that position, we have to look at how do we take what we have? How do you take what you have? Because it's not going to be fixed overnight. Medicaid expansion is not going to happen across the entire United States overnight. It's a process. Everything's a process. But how do we take what we have and collaborate, break down some of those silos, even here in Wichita? I mean, sometimes I'm amazed at showing up at different meetings and you have different groups that are attacking the same thing and everybody's doing the same thing. And I think about all the administrative costs associated and tied into that. And what could happen if we all got on the same page and collaborated and eliminated some of those costs so that we could make things more affordable and more realistic and reduce the cost in the system overall. It's kind of two parts. I think we as leaders in the healthcare industry, we have to look at what we can do to get costs to where they need to be. But then we also need to educate our communities on what their responsibilities are to, focus on prevention, getting them to the doctor. But if we're telling them to go to the doctor for prevention and early intervention, so it's on the lower cost of the system, we need to open the doors. There needs to be access. We can't make it so difficult for people to have access to care and then say, oh, it's going to be a right, but it's only a right when you're dying. I mean, when you're dying, that's when you have the right to health care in this country.
That's really compelling. When my twins were born, my twins were early. And I was in the NICU all night watching them. And you start to bond with the other parents there. Occasionally, a parent would lose one of the babies. It was really difficult. I was trying to imagine myself explaining to that parent, no, this baby doesn't have it. It's very compelling. But I think Dr. Josh has a rebuttal.
Yes and no. Because what I would say is, and the mistake that's often made is we ask a question like this and then answer it in a variety of ways that don't stick to the structure of the question. The question was, is healthcare a right? Which brings the topic, the debatable information as what is a right, what is not a right. I will agree with 100% of what the panel has said. Sad stories about sick children, sure. And we need health care, absolutely. And it's a complicated, expensive, bureaucratic system, indeed. That doesn't make it a right. In fact, I would argue if we really wanted to fix those things, quit talking about it being a right. We know what Kansas is doing with the right to education, and health care is immensely more complicated than education. If nothing for the fact that it covers more people for a longer amount of time. We're not doing it well. So why do we do more of it? And to even argue the idea that health care right now is synonymous with health insurance. So we argue, is health insurance your right to insuring risk? That insuring risk is a business proposition. You don't have a right to that. So if we don't want to discuss what rights are, then we can just talk about whether or not it's good to provide health care to lots of people, and we'll all feel warm and fuzzy and say, yeah. But that doesn't change the bureaucratic, expensive, cumbersome, broken system that we have. So,
Isn't that the conversation that we tend not to have?
I think so. I think we focus on the problem all the time. We all agree it's broken, so no one will stand up here and have awkward conversations and difficult conversations about what to actually fix. Because honestly, if any of us thought we could fix it, we probably would have proposed that by now. So we tend to roll forward into the momentum of the status quo. It's broken, but it's moving. So we work inside of the system. Call it a right all day long if you want. It doesn't change the fact that it's not working.
So talk a little bit now about how you've addressed this question
Sure.
in your own practice.
So for me, I think the most important thing that it comes down to as an Ayn Rand-based objectivist, individual rights. And if you protect the rights of the individual, you protect all rights. And fundamental in that is economic rights. Because if you protect economic rights, you protect their access to everything else that comes from that. Home, food, clothes, medicine, everything. So what we wanted to do when we created our practice, we said insurance isn't bad. We've blamed insurance for years. It hasn't changed anything. Insurance and healthcare is a tool, and we're using it wrong. I love my life insurance, or at least my wife will someday. And it works, and there's only one form to fill out, and I can't file it twice, or they deny it automatically.
What kinds of things are you doing specifically in your practice?
So we wanted to build a practice that was free of insurance, but made insurance work better, and that doesn't make a lot of sense. So what our clinic does is it's an insurance-free practice. We do a monthly membership based on age, $10 for kids, $50 for adults, for unlimited home visits, work visits, office visits, technology
Say
visits.
home visits.
Home visits, unlimited, $10. No copays, free texting, emailing, video chat, everything. Then no copays for anything we do in the office. Any procedure we do in the office is free of charge. EKGs, stitches, biopsies, joint injections, ultrasounds, DEXAs, Holter, spirometry, urinalysis, rapid strep throat, urinalysis, cryotherapy, lesion removal, minor surgical procedures, free. Then we also do wholesale medications and labs. Kansas, we're lucky to have the economic freedom for doctors to be like one of 44 other states where we can dispense medications directly to our patients. So I can do it wholesale. So thinking outside the box, I get most medicines for 50 to 95% less than retail. We've gotten chemotherapy for a patient before, wholesale through an economic model, not a charity model, just to clarify, for 99% less, going from name brand retail to generic wholesale. We can also do the same thing with lab tests. The CBC is $1.64, and that includes my 10% markup. Damn capitalism. And we can do that with radiology, pathology, specialty consultations. So we can come back and decrease the cost of employer insurance in Wichita for the last 4 to 5 years by 30 to 60% in the first year. We have some employers like Johnson's Garden Center who pays less for health insurance each year going forward as they get a better plan that covers more people. So it's through economic solutions that we'll find a better health care problem that will fix this. So you'll never fix the fact that some people are really sick. And I don't say that coldly. I say that to be, in all seriousness, bad things will happen. That's why we have insurance. You know, my ending in my life is the worst thing that can possibly happen, so I insure it. And the next is my house burning down, and so I insure that. And we use health insurance to pay a $10 copay for a medicine at the pharmacy, and I can get that same pill, 1,000 of those pills, for $8.
I have one more question. Why aren't more people doing that? It sounds like you figured something out
aren't
that
more
the rest of
people
us
doing
are
that?
trying to
That's-
figure out.
It's a great question. If I knew that, I'd be richer. Actually, there are. When we started our practice, September 2nd, 2010, less than 1% of the doctors in the country would consider an insurance-free practice. Now I speak, maybe not every month, but 8, 10 times a year on this. There are a couple national conferences, and now we have maybe 1,000 doctors doing this model. But the National Society for Family Physicians polls it internally at 34%. So in 5.5, 6 years, we've gone from 1% of doctors interested in a model like this to 34%. And correlating that with insurance companies being supportive of the model and seeing where they benefit, as well as patients and employers.
Do any of you other panelists have any comments about this?
Actually, my comment has to do with health disparities.
Fine.
Well, well, as the federally qualified health center and the CEO of that health center, and looking at the intricacies of how to make that work and take care of people who present at your clinic, regardless of their ability to pay, whether they do have insurance, they don't have insurance, whether they can pay a copay or not. I'm interested about the other side, like the malpractice. I mean, how do you guys protect yourselves from?
Our malpractice is 40 to 60% less, depending on the state, because we take care of fewer patients per doctor. But the number one factor for this malpractice company is quality of communication back to patients, and for us to have unlimited phone calls, text messages, emails, appointments, and no copay. For free means no barrier for patients to communicate back with us when healthcare isn't going as well as planned. And so you don't let an infection fester for a week because you couldn't get into the doctor. You text them, they text you back, you get medicine. It's a faster care.
And I'm thinking about the pool of patients you would serve. I mean, because when we look at health disparities, these are usually patients, I hate to say sicker, these are people who have historically gone without access to care for so long that by the time they do present to someone's medical facility, they're really, really, really sick. And it's not a 15-minute appointment. It's like over years.
So this
I'm
might be a
gonna-
good idea, but maybe not for the
'Cause I'm
people that you
thinking-
help.
Well, I'm thinking about supply and demand. I'm thinking about the supply of patients you guys have, and the demand being how sick they are.
Let me stop
somehow-
here, because I think we've put him under the microscope.
I'm sorry, I'm just.
No, I'm fine.
But I'm happy to come back to
Oh,
it.
yes. But just from a financial model, just what does that look like for the providers also? And
We make 40% more than the average doctor, so fewer patients and happier overall. So we wanted to create a model that made sense for patients, doctors, employers, physicians, and the public. And so just real quick, so we can continue. Steve Covey has a great book, The Third Alternative, and I do think there's an alternative between insuring everybody and not insuring everybody. And you're right, there's a percentage of the population that won't be able to afford anything, and that's a perfect time for the government to step in. But right now, the government's paying $50 for CBC that I get for $1.64. So to stay out of the politics, because I think they're both wrong, the left side, to use generic terms, wants to provide more care for more people. Again, an excellent goal. No one will argue that. And the right, for generic terms, although you couldn't tell it looking at this legislation, wants to be financially sound, so we only have so much money to go around. So we can't do both, take care of more people and be friendly to the budget. But if we get medicines, labs for 95% off, then you can provide 20 times more care in a budget-neutral, budget-friendly way. So that's how
I'm sorry,
we
let me
take.
let Annie jump in.
Yeah. So I was thinking a little bit about some of the numbers that Steve gave earlier that he opened up with when he talked about if you live below the poverty line, you're 2 times more likely to smoke. If you don't have a high school diploma, you have increased rates of cancer. So you might be surprised, but I'm going to pivot back to the investments that we make in early education. And so if we're talking about supply and demand, as Teresa brings up, if we want to reduce that demand, it helps to invest on the front end. And we do have the resources in this state to do that. There, as Dr. Humbert said, will always be sick people, but we can reduce the number of sick people by investing in the programs and the services that we do know help address those disparities.
Melody, did you want to pick up with the question that you wanted to address before?
I'm trying to get back there, quite honestly. I think that the model that Dr. Umber has described is viable, and then when you look at being able to move from, I would say, consistently saying that it's about defining a right. And what I thought I heard Dr. Umbar also say is that it's about individual rights. And if you're taking care of the individual rights, then you're going to automatically be able to kind of spill over into the larger population. I think that when you have that perspective and you're looking at it from a disparities lens, disparities is the overarching lens that we were discussing. And if disparities is the overarching lens, then you have to look at what is causing, what are causing the behaviors that is creating the disparities, that creates this disproportionate number of people, particularly people of color, African American and Latinos, that have poorer health. And if you have basically an economical model, which is what I'm hearing described by Dr. Umber, that this economical model is not necessarily going to be for everyone. So when being able to promote and market this model, how does that affect, impact, or touch reducing health disparities? It's a question that I would pose back.
Sure. I think the important thing is I ran for office, and in that, among other things, I learned from a tax policy point of view, the only thing that matters is jobs. Okay, if we don't have more jobs, we don't have more tax dollars, we don't have more options for the government, we have more people who need more help in terms of state budget issues. So if we can go back with this economic model and decrease employer health insurance by 40 to 60%, if we did that for 10% of the employers in Kansas, we'd have an economic boom the likes that Reagan would be jealous of. And that would mean more people, more disadvantaged people who get on a job who don't need help and now can buy their own health care, but also have the power of being a consumer. They can invest in their own education, they're healthier, they see a future, but they have capital, they have economic rights, they have something. Milton Friedman, who is one of my favorite economists, mostly just because he looks like an old senile grandpa, he has a great quote, and it sounds a little rude, but I don't mean to be rude, is the problem with poor people is they don't have any money. And it sounds, like you said, off the cuff, a little rude, but it is to the point. I resemble that. Yes, I understand. I've been there. But they were not lacking a government system to say, here's shoes, here's food, here's house, here's medicine, here's education, here's all these things. So,
I'm sorry.
Yeah.
I
John.
wanted to shift gears a little bit and get to the question of health equity and what that would look like. We have very different people here, and I think they'd have very different opinions about what health equity would look like. Annie, what would it look like for you?
So, I mean, I think if we were talking about what equity looks like in Kansas, I mean, I think it's about reducing and eliminating barriers to access, which is not something I think we've done over the last several years in terms of policy decisions the state has made. I also think, as we've talked about repeatedly, it's about investing on the front end, investing in early care and education services, investing in K-12. You know, I mean, I think Steve said to start, how do we help those kids, which is the frame that I'm coming at from Kansas Action for Children. And so I think it's asking that question for every indicator that we see, every metric, every community, every population, and asking how do we address or how do we impact that indicator, that ranking, that community, that population to give them access, full access to better health.
Teresa, let's go to you.
Although I'm still stuck, I was trying to add up how much it would cost for my family of 7, my brother's family of 7, to afford $50 a month, and you know.
10
but
for kids.
well, what about older kids? Because sometimes in some families you have what, like when you're 18.
0 to 20.
0 to, okay. So we'll talk about that offline, but because I'm thinking of, you know, when patients come to the clinic and you ask them to fill out their family income, and you're talking about families that have 7, 8, 9 people in them, if you talk about blended families. And if you start doing the math there, it gets very expensive.
But in terms of that picture, what would health equity look like in that picture?
Well, I can tell you at Health Court Clinic, again, you guys know I was a patient, kind of started out where I started out and going to where I am now as a board member and looking at healthcare from both sides. I'm also a social worker, master level social worker, so looking at the mental health side of what our health system looks like and trying to integrate what health equity looks like to Health Court Clinic and what it will look like in the very future is having an integrated health complex, to be honest, where you can come in and present at this place, where you can get access to integrated care services, where you have a cross-functional team of individuals working together with you to help reduce what the overall cost of healthcare is, but then improve your quality of life. So health equity is more than just, you know, let me get into a doctor's appointment. It's sit down to me. Maybe I didn't grow up where you grew up, and I don't understand what it means to go to the doctor for preventative care. Or maybe I don't understand how important my health is related to my zip code, related to my educational level, related to my, I mean, we take a lot for granted that people know this. You don't know, if you don't know this, then you're ignorant, not ignorant because you're ignorant, it's just that you've never been exposed. If you've never been exposed to something, take the richest person in the world and take them to a neighborhood and have them fill out the bridges out of poverty. Could you survive in the hood? Or could you survive poverty, and watch what happens to that individual? So if you're not exposed to something, you don't know. So what we need to do to create health equities is to really work with people and see where they are, work with ourselves to be more culturally competent so we can meet people where they are. If you're in organizations that are supposedly addressing health equity, look inward at yourself and at your organization and decide or look at how can we be better and what does health equity mean to that organization? Because health equity is something that's so broad and generic, and if I ask every person in this room to take a moment and write the definition, you probably have about 100 different definitions of what health equity is. So I think until we decide what health equity is, it's going to be hard for us to tackle it. And that's why I think it's such a complicated issue that we each time come together and go, what are we going to do? Because we don't understand it.
And what I love what Teresa is saying, and because she keeps saying we.
Yeah,
Because it's not an individual. It can't be done with an individual approach. It has to be collective. It has to be comprehensive, and it has to be holistic, which is what I'm hearing you say when I think of holistic. When I think of integrated and being able to, and viable partnerships.
Private, non-for-profit, cross-discipline. We all have to come together and look at our community because we care, and sit together and look at our resources. Many organizations get grants, they get, different funding mechanisms. When we all sit down and look at what we do and what we can do to address health equities as a community, that's when we'll move the needle. But as long as somebody's benefiting from the negative outcomes of this community, somebody's benefiting from when you write a grant and you get to say, oh, we have the highest infant mortality rate for African American babies on this side of the Mississippi River. You want your grant application to look good so you can get some money, but then when you get the money, what are we doing to really move that needle? Who's holding us accountable and responsible within our communities to say, let's do something about it?
What do you panelists think are our primary barriers to making progress on this issue?
Ourselves.
The succinct answer.
No, it's not lack of coordination. We coordinate well. We all coordinated ourselves to this room. We all talk about it. A lot of what was said was absolutely 100% right, in the wrong direction. It's not a solution. It's a description of the problem. And investing in education, absolutely. Investing, though, implies a return on investment that is years from now. What can we do today when we leave this room to make healthcare cheaper? That's what the problem is. The thinking that got us here isn't the thinking that will get us there. And we keep trying to fix the same problem in the broken system. We've been doing it for 20 years. It sure keeps us busy. Hasn't created something different. And I'm not trying to pat myself on the shoulder, but we do have to say, how do we do it different? So there's
So
400.
you're saying that maybe it's our preoccupation with addressing health insurance.
Yes, yeah, I think that's one of them. The problem isn't the problem. The problem is how we think about the problem. And so we keep trying to say, how do we fix insurance? How do we fix it so we don't need as much insurance? How do we change it so less than 5% of the people in the country will spend more than $5,000 in health care in a given year? And that's in our current bloated prices. Less than 20% of people will ever hit their deductible in their lifetime. What most people are suffering from is a lack of quality health care that's accessible like groceries. That medicine, a lab test that's $50 somewhere else should be $1.64. Why? Because that's the real cost of that. And so the government is in our way. We are in our way. As chairperson for Rainbows, though, we stopped going after grants, state grants, because I'll make these numbers up for convenience on my part. A $50,000 grant costs $30,000 of paperwork to do. So the state's spending $50,000 but getting $20,000 in value. Same thing was happening when you're paying $100 for a doctor to see a patient, but the doctor's overhead with 7 employees each is so high that they're walking away with $20. So if we just want to fix it, cut out the red tape. MIT did a study on Oregon's Medicaid system, and 20 cents on the dollar got to the recipient. We can't even hand out money well. If we just walked out and gave them 50 cents, we would be 2.5 times more effective at what
Your argument is just how we frame it.
it's how we frame it and how we fix it. But in that sense, we don't need to invest in the future. We need to invest $10 per kid today, and we could get unlimited quality health care going forward for a fraction of the current budget.
The very first thing we need to do, this is the Reshaping Our Reality Conference with a bunch of well-to-do people here. I would love to show up at the Reshaping Our Reality Conference with the people from 13th and Grove and Plainview and up on the north and east side. I would love to be at that conference and let them tell us what reshaping their reality would look like. And then I think that's where we start. Too many times we don't include that piece. And I'll give you a great example. We do listening sessions at the clinic. So last month we had a listening session with our refugee population. You guys know we have over 1,000 Democratic of the Republic of Congo refugees in our community. And they're living and surviving right below the radar. And we know what's been happening around refugee health in our community, and we know those numbers. We brought in 12 men, 12 refugee men that represented the Democratic Republic of the Congo, Ethiopia, Burma, and Afghanistan. And what those men told us at that listening session was that they wanted to be empowered so that they could understand their health care rights. Summed up.
So a lack of information.
Lack of
would be one
information.
the barriers.
That's that exposure. And we're going way up here, and we think, we're going to do a whole health day for refugee men's health. It's Men's Health Month. And so to bring them in, and this is what they told us that they wanted, because they felt disenfranchised. They felt disengaged to the healthcare process because they didn't understand what their healthcare rights were, coming from different countries and working with the World Health Organization and all these different things and getting to America. And the one guy, he said he was so concerned about his blood that when he goes to the doctor, they take so much blood for him. And in his culture, they took so much pride in their blood, and he wants to know what's happening to his blood. And nobody invested in that interpreter to sit in a room and talk to him and explain to him what was happening to him. So sometimes when we want to reshape the reality of people that we're impacting, we have to hear what their reality is and what it looks like and what they aspire to want or have or be before we sit here and try to decide what it is that we're going to do on their behalf.
Information input.
Coming from the ground up. So we have the knowledge up here, but we need to somehow connect it to what the problems are as well, so that we can move forward. Sorry. Okay.
Well, this is such a rich conversation that it just takes a moment to really try and kind of condense it down to something that is a takeaway. Because I think that that's one of the reasons why we're here. Is what are we going to take away from this? What are we going to do when we walk out of here? Are we going to do anything any differently? Are our minds going to be informed from a perspective that that we will really feel as though we have not only the wherewithal, but also the power to change and to do something about health equity? So when I think about all of the technical fixes that I'm hearing here and there, KLC terminology I'm kind of throwing in there, as opposed to adaptive. This is an adaptive This is an adaptive challenge that we are dealing with here. This is going to take time. It is going to take our energy, yes, it is going to take our resources. But I keep saying, I'm hearing it, it is a we issue. It cannot be done independent of one another.
What kind of barrier is that? Is that a knowledge barrier? Is it a caring barrier?
I had a conversation with Annie. I think it's a will barrier. I think it's that who has the will, who has the true commitment to step out of their comfort zone and really start to talk about and figure out the resolution and solutions that we can comprehensively and collectively bring together to start to deal with health disparities and health equity. I think the barrier is will, and it can be individual will, and it can certainly be what I would call a collective will, which is what we see in the legislature. So how do we move people to a point and a place where it is so urgent and important to them that they will indeed engage, hear what's being talked about, take the time to dig a little bit further and really understand who this affects and impacts and what your role is in resolving it, because we all have one. We all have a role to play in reducing and or eliminating health disparities. And I'll keep coming back to it because health disparities is a historically rooted, man-made issue. It is not biological. It is not genetic. It is something that we can indeed prevent, but it will take will from all of us.
What was the question?
What are the,
Yeah.
what kind of barriers are we facing in order to make progress on this issue?
I think some of the barriers that we're facing are policy choices we've made in the last few years. I referenced those earlier. I think we've made some choices around tax policy that have drained us of our state of the resources that we once had to invest in critical programs like the Safety Net Clinic and critical programs like early education and care and critical programs like mental health services. And, you know, if we look at, you know, the data points, we're dropping in rankings, and Steve illustrated that earlier. At the same time, we've pulled back in supporting these programs and services. So, I mean, I think we've also made trades and investments and policy choices in the last 2 legislative sessions, limiting access. I don't know if I heard correctly earlier that every person has access to government services, but I would argue on the other side of that, that's actually not the reality of Kansas low income and Kansas families living in poverty, that we've significantly increased those barriers, and subsequently we're seeing the number of kids accessing child care assistance and families accessing cash assistance just plummeting. And what we're going to see now in a couple of years is the number of Kansas kids living in deep poverty having skyrocketed. At the same time, we will have wiped out the early education system. And so, I mean, I think it comes down to resources, and the policy choices we're making as a state don't reflect the will that Melody said to address health inequity.
Do we have any questions from the audience as we are beginning to wind down? I'd like to take some questions from the audience. Yes, sir.
We have an expert up here who's figured it out. He's figured it out, right? It's health care. But I would like to say that this is not just about health care, it's about health equity. And so it's much broader than that. But it's much easier for us to go to the health care solution. But at the same time, we know we still have challenges with, you know, the environments that are that so many people have to live in, that creates incredible amounts of stress and anxiety and the inability to purely just function. So, just an observation.
Great. Another question? I saw another hand go.
Yeah, so in some ways, I'm probably just parroting what Jeff just said, but I feel like we actually started this panel off on the wrong foot, asking if healthcare is a right, because I think I agree healthcare is not a right. Health is a right, and we have a terminology issue. So our barrier is a terminology issue, where we continue to refer to healthcare as health, and I think we all have agreed from or have seen from previous presentations today that health is not healthcare. Sick care is healthcare, and how do we get to those uninformed and people who didn't get educated in health and healthcare? How do we get to those groups to talk about health as prevention? We're not starting, you know, if we want to reshape our reality, we got to stop starting with healthcare and start starting in the right spot in the first place.
Another question.
Taking both of those comments, right versus right investment, and what's the right investment? Innovation and a new model, coordination and integration, equity versus disparity, and what's the right place to start? What's the right investments to make?
Dr. Umber, I'm a family physician also. I have a question. What panel size does each physician manage in your model?
Currently, we recommend 600 to 800 patients. It depends on the model. Some pediatricians would see 1,200. So the next common question we get after that is, this will worsen physician shortage. Well, there's 300 million Americans and about 1 million doctors, so roughly we have about 300 patients for every doctor. By the time you factor it down and change models, we have plenty of patients to go around, plenty of doctors to go around. So again, it's not what the problem is, it's what we think the problem is. They say there's a physician shortage of 50 to 130,000 doctors by 2005, the American Academy of Family Physicians does a poll a study that shows 22 to 40% of a physician's day is spent doing non-clinical paperwork. So if you just took the 22%, the lowest, most conservative version of that, and multiplied it across the physician workforce, it would be the equivalent of 165,000 full-time equivalents back in the workforce right away. So we have more than enough doctors. The problem is that we're hamstringing our physicians with unmanageable levels of paperwork. So our model would actually improve the physician shortage because it would improve efficiency, but also doctors who are burning out and ending their career 3 months after finishing training, or 3 years, means we have a whole lot less physicians. The current model is pushing doctors out. Our model encourages medical students to go into primary care. It extends the life of the career of older physicians. It helps avoid burnout. So I think there's a lot of ways our model would improve access to care from a total volume.
We have a question in the back.
Thank you, Mark. My name is Jim McLean with the KHI News Service, and I don't want to pick a rhetorical fight, but as long as,
Fight about anything, so.
or a quibble. I don't want to quibble, but I do think terminology is important. In a moment ago, and I understand the impulse and the desire, the statement was made, healthcare is not a right, health is a right. Well, rhetorically, that just doesn't work. You have the right to vote. You don't have a right to the utopia that you hope to create vis-a-vis your vote. I mean, health is a state of being, frankly, that not everybody is. We're not all born with an equal level of health. What you can expect in a society is to have an equal right to whatever society bestows, i.e. a healthcare system, whatever it is. And so I do think, yes, it's wrong to pigeonhole this conversation as it being about health care. Nevertheless, when we're talking about policy options and what we can reasonably expect to agree on, we do need to talk about the mechanics of what a society can bestow as rights. And health isn't one of those things, I don't think.
Any other questions?
Yeah, this is just a comment. I think I never have liked the question, is healthcare a right? Because I'm not enough of a philosopher to know how to answer that question. I do think it comes down to the fact, my question would be, don't smart societies, capable societies, invest in their people by providing health care and early education and a variety of other things to build the population into a successful, economically viable group of people. And frankly, I think it is an adaptive problem in Kansas because we are so overwhelmed with anti-government language, and we can't define common good anymore other than to say it's created by a free market. And I frankly don't believe it is created by a free market, and I think markets are under the control of man the same way everything else is. So I think there's a deep philosophical divide on this panel, which represents really the ongoing struggle in Kansas to prevent self-interest from totally dominating collective interest. And we no longer have the ability to use government to define the common good or to build the common good. And so I think that's my take, that's my political overlay, I guess, on the debate here that I experience every day.
I think that's an excellent point. I met a doctor who practiced at Howard University Medical School. He explained to me that at Howard Medical School, 30% of people who had cancer and were being treated there got their initial diagnosis in the emergency room. There was a tremendous lack of trust on the part of the African American community to even go to the doctor. He told stories about people believing that once air hit the cancer because of a surgery, it would explode, so people wouldn't go. I don't think that person is going to make these kinds of divisions between health and health care. And how we think about it and how we talk about it does matter. So I appreciate that point. Do we have any other questions? None? We have one.
I just want to say how much I appreciate this conversation. I think it took a certain amount of courage for the doctor to take his point of view, and I think it took a certain amount of courage for the Kansas Health Foundation to have this discussion, because it's so different than any other discussion I've ever heard about this at a public health conference. And I agree with the doctor, and I just want to make sure that people, I think, get his point, which is he wants to lower the cost of health care, which he believes will then allow more people to have access to it. And I think that is a conversation that we often don't have in public health. We often have this conversation about how do we provide more of this grossly overpriced health to people, and it's completely unsustainable. So I do believe, I mean, right now, Abraham Lincoln had a speech where he said, trying to remember the House divided speech, it will become all of one thing or all of the other. Right now we have a healthcare system that's sort of private and sort of socialized, and it's like the worst of both. And my daughter's 3 months old. I hope by the time she's a senior citizen that we will become either all of one thing or all of the other, because right now we have the worst of both, in my opinion.
Well, I don't disagree with you. And I think you're absolutely right. And I think I come across economically cold or maybe even disinterested, but obviously the will to do this has taken $2 million of my life to build and work and moonlight in ERs to throw into a clinic model that everyone told me wouldn't work, couldn't work, shouldn't work, and now it's thriving, and we've helped 185 doctors convert to this model in the last 2 years, because we believe that there is a solution where we get both. I want to take care of more people. I want more equity, and the way you get more equity is that Charles Koch pays $1.64 for his CDC, and everyone else does. It is that if it's $50, the opportunity there is bad, and people will take our model and say, because it's market-based or cash, it must work best for the rich. Sure, it works for the rich because the rich can buy whatever they want. They said, if you're really going to fix something, this works best for the sicker and poorer you are because you have less money. But the system where we've created, we haven't rewarded physicians or healthcare providers for innovating and lowering costs. So the migraine medicine that's $100 to $200 retail price at the pharmacy, I get for $4.99. My patient gets for $5.35. So if the lower and poorer you are, the more good I've done for you. That's days worth of labor back. If you put that savings back every single month, not only is your quality of life better, your opportunities for steady employment are better. Steadier employment, less stress, happier home, more time with the kids, focus on their education. It all starts to come back through economic benefit. And that's a model that, even though I think we push back against sound business, I know my med school did, but it's actually, the obstacle is the path. The cost of care, fixing that will open up this utopia of healthcare, just like we are all walking around with supercomputers, mind you, in our pocket because of good business, good value. So our patients will continue to see things. They have a $110,000 machine that for testing things in my office that they get for free because I invested in a business that provides care for them.
Let's park right now. Let's give our panelists a hand for a great conversation today. Thank you all very much. This was an incredible conversation for me as well. We have some incredible people working on this issue, and you just can't solve this problem in an hour. So thank you all. 2 hours.